Dr. Crittlebaugh is a pediatrician and director of a pediatric obesity clinic in Dallas.
I see patients from all around the Dallas area. We see patients ranging from ages 6 to 18, and we specialize in treating children whose body mass index is already above the 95th percentile for age. We are able to offer not only comprehensive care in our clinic for their medical problems associated with obesity, but we also offer a 12-week program designed to teach the whole family about a healthy lifestyle.
Dr. Scranton practices in a multi-specialty group practice in an area without a pediatric obesity clinic.
I have 7 partners and we see about 150 patients a day. I personally see about 35 patients a day, and without us access to a pediatric obesity specialty clinic, the management of these children falls on our shoulders.
I have the luxury of spending up to 30 or 40 minutes with my patients and discussing their weight and counseling them about all the needed interventions, both in their diet and physical activity, as well as the medical treatment for their comorbid conditions.
I have about 15 minutes per well-child check, and to fit obesity counseling into that 10 to 15 minutes along with other preventative services is difficult.
What obstacles do each of you face and how do you overcome them?
Well, as a primary care physician, I think some of the biggest obstacles that I faced were, first of all, my own feelings of being overwhelmed with how to address this problem and how do I address it with parents and families without them getting offended or feeling like it was a cosmetic issue instead of a health issue, which it is. And then the fact that there are no proven office-based treatments, so I didn't really feel like I was coming from a position of someone that, was able to really help with this problem as a primary care provider. And once I kind of worked through some of those issues, then the same old things that everybody else brings up, such as time, reimbursement, compliance, and those sorts of things.
I had a lot of those same challenges when I was doing primary care medicine before moving to a pediatric obesity treatment sort of environment. When I say, well, why did your doctor recommend that you come here? They'll say, well, my child's at risk for diabetes, or my child had an elevation in this lab value. And I have to even probe a little bit to say, and did your doctor mention anything about your child's weight? So I think, we're reluctant to talk about it and families are reluctant to talk about it. And we have to find ways to bring it up with families. I would, during the context of a well-child visit, I would ask a family or a mom, what are you concerned about with your child today? And we'd go through mom's list of things that were concerns. And then I'd sometimes say, well, I see something that I'm concerned about with your child. And I'd say, I think his weight is beginning to creep up, or his weight has now gone into the category that doctors begin to worry about as a health problem.
Or lately I've been using basically that your child isn't healthy.
Mm-hmm. So how do you bring that issue up in a delicate way without alienating or frustrating the family? We specifically avoid the use of what I call the O word, which is obesity. We are often able to couch it in phrases such as risk for diabetes, risk for even heart disease if there is that present in the family. So establishing rapport with these families is key.
Texas Pediatric Society pediatricians from a broad range of locations and specialties have organized suggestions for obesity diagnosis, evaluation, and management, presented in the following algorithm. Keep in mind, your practice's needs may necessitate modification of this algorithm. The algorithm is divided into 2 categories: ill child visits and well child visits.
We distinguish ill child visits from well child visits because ill child visits need to address the primary illness or chief complaint, the reason the child was brought into the clinic in the first place. Ill child visits can be used to identify other problems in the chief complaint, but it's not always reasonable to treat those other problems. If a child is overweight or obese, we encourage treating the chief complaint, but briefly discussing weight with the patient and their parent, but scheduling a follow-up or if needed a well child visit to address nutrition and physical activity more in depth.
During an ill visit, determine if the patient is overweight or obese.
We can't calculate a BMI and really determine whether the child is overweight if we don't have their height. But I'm sure many practices are not in the habit of checking a height every time the patient comes to the office, particularly if it's an ill visit.
Well, I think it's very, very important to do height as often as you can. And I know in our practice, it's been a long-standing practice just because growth is one of the things we're always monitoring in pediatrics to get a height on infants and toddlers pretty much every time they come in, even if it's for an ill visit. Now with the older children, you know, if you've had our policy is if you've had a height within the last 3 months, you don't have to have one. The height that if it was just, 3 months ago, can go ahead and be used to calculate a BMI. And I do think that's reasonable because when we weren't doing the heights routinely, we missed growth issues and that made other issues for us. So it's not just for this obesity that it's a good idea, just as a standard of care, it's a good idea.
I think just as you would measure and monitor the blood glucose on your diabetic patients, or if you have a child even with scoliosis that has been progressing, obesity, since it affects 25 to 30% of our children, really needs to be considered a chronic problem, and part of following that problem is getting the information and the data that we need, and it just so happens that the data we need for this problem and is to follow the BMI, and so getting a height would be a natural progression of that. The inconvenience you'll have on this end of the problem is not nearly as inconvenience as being on the other end and trying to manage a child with diabetes or orthopedic problems or any of those others. So I think it's a small price to pay.
So I think I hear you both agree that getting a height at a well child visit as well as illness visits is something that ought to be standard of practice, even if it takes a few more seconds for the nurses to obtain that.
If the patient is overweight or obese, manage the current complaint. Discuss weight concerns with the parent or caregiver. If no well child checkup has occurred in the past year, ask the parent to schedule a well child checkup within the next 2 weeks to specifically evaluate weight, along with other health maintenance issues. If a well child checkup has occurred in the past year, schedule a follow-up in the next 2 weeks to address and evaluate weight issues, including trends in BMI.
When an overweight or obese child comes into our clinic for some other illness, I bring up my concern about their unhealthy weight right then. I don't want to miss the opportunity to address unhealthy weights and lifestyles. We should be reviewing charts at every ill visit to ensure a patient has had a well child visit and BMI percentile determined that year.
If the patient is not overweight or obese, treat the current complaint and use the opportunity to encourage continued healthy activity and eating.
It's important that the practitioner identify the normal children, the kids that have normal body mass indexes, and kind of congratulate the parents for a job well done. That's particularly true if the parents tend to be a little bit overweight.
I've even had children referred in where the child is of normal size and weight, yet the other family members, parents, and maybe extended family members may think that the child is unhealthy because they are smaller than their other family peers. The quote-unquote normal child, at least from a weight and height standpoint, is now considered abnormal by the rest of the family. And encouragement is given to me by them to try to do something about that, to try to increase their weight. So we have to start with reorienting them as to what is normal.